Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology and Urology at Seoul National University Hospital. In this session, I would like to talk on the role of imaging in staging of prostate cancer. I'm from Seoul, Korea. The incidence of prostate cancer in Asia is lower than that of Europe or America, but it is higher in my country than other parts of Asia. As you see in these two graphs showing the incidence of prostate cancer in Europe and United States, prostate cancer incidence made its peak in 1990s and 2000s, and now it is decreasing. But the incidence is still increasing in Asian countries, as you see in this graph. T-staging of prostate cancer is T1, tumor neither palpable nor visible by imaging. T2, tumor confined within the prostate, so the lesion demonstration is the most important role of imaging in T2 stage. T3, extracapsular extension or seminal vesicle invasion. And T4, tumor spread more than T3. Two-stage prostate cancer better. Imaging should detect the lesion better, should detect extraprostatic extension better, should detect lymph node metastasis better, and should detect distant metastasis better. I would like to talk in this sequence. How can we detect the prostate cancer lesion better with transrectal ultrasound, CT, and MRI? Usually, transrectal ultrasound is the first imaging modality, and the typical ultrasound finding of prostate cancer is a well-defined hypoechoic lesion in peripheral zone, as you see in these four different cases. However, the problem of transrectal ultrasound is only 60% of all prostate cancer lesions are hypoechoic, and only 20 to 30% of all peripheral hypoechoic lesions are prostate cancers. In other words, this finding of hypoechoic lesion in peripheral zone is neither sensitive nor specific for prostate cancer. Here are two same-looking small hypoechoic lesions in posterior aspect of the prostate. One is cancer and the other is not. We cannot tell which one is which, and always we need biopsy for diagnosis. Transition zone cancer is not uncommon, and about 20% of all prostate cancers occur in transition zone. This is a patient with transition zone cancer, but it is difficult to imagine this whole transition zone is involved by cancer. Then, how can we improve transrectal ultrasound in prostate cancer detection? In addition to grayscale, we can use Doppler ultrasound, color or power Doppler. We can use elastography, and we can use contrast-enhanced ultrasound. Because prostate cancer lesions are usually hypervascular like this case, with Doppler ultrasound, we can improve detection, improve positive predictive value, and improve biopsy site selection. If we see a peripheral hypoechoic lesion like this, positive predictive value of this lesion to be prostate cancer is about 20 to 30%. But if we see hypervascularity of the lesion, then positive predictive value is about 60 to 70%, much better than grayscale alone. In this patient, left side of the prostate is asymmetrically hypoechoic, and the extent of this hypervascularity well shows the extent of the tumor at pathology. Nowadays, Most of ultrasound machines are equipped with elastography, either strain elastography or shear wave elastography, showing tissue elasticity, stiffness, or hardness. We need manual compression skill in strain elastography, but with shear wave elastography, machine can make shear wave without manual compression, and shear wave elastography can provide objective data of tissue elasticity in kilopascal value. Slight hypoechogenicity and hypervascularity on the left side. As strain elastography, the lesion is well demonstrated as blue-colored hard lesion, and the extent that elastography is well correlated with the extent of the tumor at pathology. In this patient, there is a well-defined peripheral hypoechoic lesion, but the lesion is hypovascular, so still positive predictive value of this lesion to be prostate cancer is low, about 20 to 30%. But the lesion is a hard lesion as shear wave elastography, and the lesion has higher kilopascal value than other parts of the prostate, so the lesion is probably a cancer lesion with about 70% positive predictive value, and was confirmed at pathology. The next technique we can use to improve cancer detection with transrectal ultrasound is contrast-enhanced ultrasound. The role of contrast-enhanced ultrasound in prostate cancer detection is still in research level, but this case clearly shows the value of this technique. This is a 74-year-old man with PSA 5.6 and negative first biopsy. There are subtle hypoechogenicity on the left side here, but not definite, and no hypervascularity at Doppler. Contrast-enhanced ultrasound was done before the second biopsy, and it clearly shows a small enhancing lesion here, and time intensity curve well shows early enhancement and early washout of the lesion. And the diagnosis could be made by targeted biopsy of this lesion. According to these studies, we can expect approximately 80% positive predictive value with contrast-enhanced ultrasound technique. What is the role of CT? Early phase contrast-enhanced CT may show early enhancing prostate cancer lesion exactly same as dynamic contrast-enhanced MRI. But the main role of CT is evaluating spread of the tumor in advanced cases. We can see extensive lymphadenopathy in periaortic area and pelvic cavity in addition to the primary prostatic lesions. MRI is definitely the best imaging modality for prostate cancer evaluation at this moment. This is a patient with no prostatic abnormality. Spin echo T1 and T2 weighted imaging are conventional basic sequences. Diffusion weighted imaging with ADC mapping and dynamic contrast enhanced imaging are also basic sequences nowadays. So those three sequences, spin echo T1 T2 imaging, diffusion weighted imaging with ADC map, and dynamic contrast enhanced imaging are fundamental sequences in PIRAS system, prostate imaging and reporting and data system that is nowadays popular in communication between urologists and the uroradiologists. This is a 72-year-old man with high PSA, no hemorrhage on T1 weighted imaging, and a well-defined low-intensity lesion on T2 weighted imaging, high-intensity at diffusion weighted imaging, and low-intensity at ADC map. And the lesion shows early enhancement and early washout, and these are wash-in and washout maps. This is clearly a Pyrus 5 lesion because the lesion is bigger than 1.5 cm. This is another case of Pyrus 5 lesion in an 86-year-old man with very high PSA. Among these pulse sequences, this ADC map best demonstrates the extent of the lesion, and there was an article reporting that median ADC value has a nice correlation with the tumor grade. The lower the ADC value, the higher the tumor grade. In this 68-year-old man with PSA 4.77, there is a hypervascular lesion in right transition zone. Dynamic contrast enhanced MRI well shows early enhancement and early washout of the lesion. These are wash-in and wash-out maps. This is time intensity curve. All these imaging findings are well correlated with this pathology of transition zone cancer. Next, two-stage prostate cancer better. Imaging should detect extraprostatic extension better. Although we may suspect extracapsular extension at transrectal ultrasound, MRI is the primary imaging modality to detect extracapsular extension of prostate cancer. In this patient, a Pyrus 5 lesion is evident in the right posterior peripheral zone, but extracapsular extension is not evident on T1, T2 weighted images and diffusion weighted images and ADC map. However, dynamic contrast enhanced imaging shows early enhancement and early washout of the lesion, and also you can see fine streaky extracapsular extension of the lesion. Seminal vesicle invasion is another very important part of prostate cancer staging, and usually T2 weighted and diffusion weighted images well show seminal vesicle invasion. There are low intensity prostate lesions extending into the seminal vesicle, and the lesions are well shown as high intensity at diffusion weighted imaging and low intensity at ADC map. In 2008, my group analyzed the pattern of seminal vesicle changes and risk of seminal vesicle invasion. These are patterns: normal seminal vesicle but abnormal signal intensity in the lumen, symmetric low signal intensity due to focal wall thickening, diffuse symmetric wall thickening, focal asymmetric low signal intensity lesion without mass, and apparent mass with destructive lesion. Among these patterns, the chance of seminal vesicle invasion is high in pattern 4 and pattern 5. Here is a case with asymmetric focal wall thickening of seminal vesicle at T2 weighted images, probably between these two patterns, so possibility of seminal vesicle invasion is not high. But diffusion weighted imaging, ADC map, and dynamic contrast enhanced imaging all show focal signal abnormality, so clearly left seminal vesicle invasion is present. How about this case? Asymmetric low signal intensity of the right seminal vesicle without definite mass lesion, so this pattern. Diffusion weighted imaging and ADC map show abnormal signal intensity of the lesion, and dynamic contrast enhanced imaging well shows early strong enhancement of the lesion. Urinary bladder invasion is also very important in staging of prostate cancer, and when it is extensive like this case, it is easy to detect at conventional T2 weighted images. But if the invasion is not definite but suspicious at T2 weighted images like this case, diffusion weighted images are valuable in showing bladder invasion. You can clearly see the lesion in the prostate and in the bladder wall in these diffusion weighted images. There was a nice meta-analysis study reporting the accuracy of MRI for local staging of prostate cancer in European Urology, published in 2016. They included 75 studies with more than 9,700 patients. These are pooled sensitivity and specificity in detecting extracapsular extension and seminal vesicle invasion, and overall stage T3 detection, showing quite high specificity but low sensitivity values, and their conclusion was MRI is not sensitive enough to find all tumors with extraprostatic growth. Next, to stage prostate cancer better, imaging should detect lymph node metastasis better. For lymph node evaluation, still the best way is to use conventional morphology criteria, short axis diameter at CT or MRI, and most common criteria is 1 cm, but some use 8 mm criteria. Other imaging findings such as shape, margin, heterogeneity, etc. are also important. Other techniques such as USPI or MRI, new PET tracers, and sentinel lymph node imaging is still at research level and not for routine clinical use. This is a 73-year-old man with very high PSA. These are T2 weighted images in axial plane, and you can see ill-defined low-intensity lesions in the prostate and left seminal vesicle. Also, you can see multiple lymph nodes here and here. These are T2 weighted images in coronal plane, and you can see low-intensity lesions in the prostate and left seminal vesicle and lymph nodes. Diffusion weighted images show high intensity of the lesion in the prostate, seminal vesicle, and lymph nodes. ADC map shows low intensity of the lesions. And dynamic contrast enhanced images show early enhancement of the lesions. In our practice, we do lymph node assessment this way. 67-year-old man with PSA 894 with multiple pelvic lymph nodes with a short axis diameter between 5 and 15 mm. Some are round, some are elongated. The lymph node stands out best at diffusion-weighted images as high-intensity lesions. The best way is to find out the nodes at diffusion-weighted images and compare with T2-weighted images. Then probably you can say that these 4 lymph nodes with yellow arrows are probably metastatic nodes, and these 3 nodes with blue arrows are probably not. How about these 2 nodes with red arrows? Although they are small, they are round in shape, and the chance to be metastatic nodes seems to be high. So we report lymph nodes as significant, insignificant, and equivocal. There was a meta-analysis study regarding diagnostic accuracy of CT and MRI in staging of pelvic lymph nodes in prostate cancer. They analyzed 24 studies, and these are pooled sensitivity and specificity, and you can see very low sensitivity. And their conclusion was CT and MRI demonstrate an equally poor performance in detection of lymph node metastasis from prostate cancer. Finally, to stage prostate cancer better, imaging should detect distant metastasis better. For metastasis workup, bone scan is being used as a basic study, while PET-CT or PET-MRI can be used selectively. A 77-year-old man with high PSA, T2-weighted images in axial and coronal plane show extensive prostate cancer involving seminal vesicles, urinary bladder, and multiple pelvic lymph nodes. Also, the tumor involves right pubic and iliac bones. This is a 73-year-old patient with very high PSA. T2-weighted images in axial plane show diffuse prostate cancer involving seminal vesicles. Also, there are diffuse signal abnormalities in the pelvic bones. If you see diffusion-weighted images and dynamic contrast enhanced images, you can easily identify bony abnormalities. This is a recent meta-analysis study done by our team regarding diagnostic performance of prostate MRI in detecting bony metastases. This study analyzed more than 1,000 patients in 10 studies, and pooled sensitivity and specificity were very high. And the conclusion of this study was, contemporary MRI shows excellent sensitivity and specificity for detection of bone metastasis in patients with prostate cancer. Using 2 or more imaging planes may further improve sensitivity. So I would like to finish my talk by mentioning that imaging, especially MRI, is playing an excellent role in staging of prostate cancer, specifically in detecting the prostatic lesion, detecting extraprostatic extension, and detecting pelvic bone metastasis. But we need better solution in detection of pelvic lymph node metastasis. Thank you for joining this session, and if you have any questions, please email me.